Everyone. Welcome, everyone, and thank you for joining today's webinar in the Caring for the Caregivers series. My name is Pam MacLeod. I'm from the Massachusetts Executive Office of Elder Affairs, and I'm the project director of the Massachusetts Advisory Council on Alzheimer's disease and all other dementias. Our council's goal is to develop programs, policies, and resources to improve the health and well-being of our residents living with dementia, as well as their caregivers. And one of the more significant insights that I've gained from my work with this council, as well as my own experience, former experience as a dementia caregiver, is that the well-being of a person living with dementia is influenced by so much more than their condition, and specifically the relationship they have with others, and in particular, their families. So these relationships deeply shape the person with dementia's experiences, but also the well-being of their caregivers. So building on that, today we have the privilege of listening to two speakers, Dr. Brent Forrester and Tom Harrison. They're the co-authors of The Complete Guide to Dementia, Everything You Need to Know to Help Your Parent and Yourself. Dr. Forrester is a member of our council, and his passion for people living with dementia and their caregivers is clearly evident through his words and his actions. He's the psychiatrist in chief and chairman for the Department of Psychiatry at Tufts Medical Center and director of behavioral health for Tufts Medicine. Tom Harrison is a professional writer with extensive personal experience caring for family members with dementia. So they will take it away in just a moment, but first I want to inform those of you who are live here today to please post your questions in the Q&A at the bottom of your screen or the chat box. And at the end of our session today, there will be time to answer your questions while we're live. And there'll be some time also to, throughout the program, please feel free to put your questions in that chat or Q&A. So thank you again for attending today. And now I'd like to ask Tom Harrison to turn on your camera and your mic so we can hear from you next. Thanks so much, everyone.
Thank you, Pam. And thank you also, Molly and Liz and everyone who put this together. And thank all of you for being here and listening. It's a great honor to be here. I'm Tom. I'm a professional writer. I had two grandparents with dementia. My mom had dementia, and I was her sole caregiver for years. And as a writer, I quickly discovered that there were no books out there that told the truth about being a family dementia caregiver. And I was determined to write a book that would tell the truth and also help families, if possible, to get through this difficult experience as best they can. And I'm incredibly privileged to work with Dr. Brent Forrester, who is a brilliant clinician, a brilliant researcher, and just a fabulous human being. And it's a great honor to work with him. They don't tell you the truth about being a family dementia caregiver. And by they, I mean the medical establishment. Now, most doctors. Now, if you have a doctor who is a specialist, who's a geriatric psychiatrist, or who happens to have personal experience with it, maybe they know about it. But generally, doctors don't know much of anything about being a family dementia caregiver. They don't know much about dementia. And that's because historically, there's very few medical interventions there have been for dementia. So it gets covered in a very cursory way in medical school, and that's all they get. And when they're talked to a family member, they don't really know what the experience is going to be like. And typically they say things like, well, it will gradually get progressively worse over time. That does not in any way prepare you for what this experience is like. So let me tell you the reality. The reality is caring for someone with dementia is way, way, way harder than caring for someone with any other illness. Period, full stop. That's a fact. Why is that? One, this is a very intensive caregiving experience. Not necessarily at the beginning. The beginning is not so bad, but as the disease progresses, it becomes nightmarish. A quarter of the people who do this more than 40 hours a week, every week. Half report that they've given up their social life, they've given up time with family, they've given up their hobbies and interests. 4 out of 10 say their stress level is extremely high at any time. A third have stopped exercising completely. 18% report that their own physical health has been damaged as a result of dementia caregiving. And not only is this incredibly intensive, but it's also incredibly lengthy. Virtually everyone who does this for at least a year, and a third of people will do this for more than 5 years. So extremely intense and also extremely lengthy. And that's not all. With any other illness, you can at least expect the person you're caring for to cooperate with you. But with dementia, no, the person can't cooperate and may be suspicious and resentful. With any other disease, it's predictable. You at least know what you're going to be doing day to day. With dementia, you don't know from 1 hour to the next what you're up against, which is extremely stressful. With other diseases, you will get social support, because if you say you're caring for someone with cancer, everyone will say, oh, that's horrible, and support you. But if you say you're caring for someone with dementia, they're likely to say, oh, so you forget where they put the car keys sometimes. They don't get it. And so they're not able to provide the support that you need. Dementia is embarrassing. People with dementia often engage in behaviors that are socially inappropriate or offensive or humiliating. My mom took up the habit of walking around in public stark naked. That just doesn't happen with other diseases. And people who care for dementia often experience tremendous amounts of guilt because of what they have to do for their loved one. That doesn't happen with other diseases. And with other diseases, at least the person might thank you for all you're doing. But with dementia, they can't thank you. And again, they may be suspicious of you and think you're out to get them. So it's an incredibly difficult disease to care for. And it's also sneaky, right? Because it's a very serious illness. It's a progressive, debilitating, ultimately fatal brain disorder. It's every bit as serious and tragic as cancer, diabetes, heart disease, kidney failure, whatever. But it doesn't start out that way. At the beginning, it doesn't seem that bad, right? The person's not in pain. They're not hospitalized. There are not a lot of medical decisions. The doctor's probably not telling you all that you're in for. And as a result, family members make the big mistake, right? The big mistake is they say, oh, this doesn't seem so bad. We can probably handle it. It's just kind of getting older a little faster, and we'll take it one day at a time, take it as it comes, cross those bridges when we get to them, right? That attitude is a recipe for disaster. The only way to maintain your sanity if you're caring for someone with dementia is to cross every bridge you can before you get to it, and as long before you get to it as possible. Here's why. Remember, I said the doctors will tell you it will gradually get progressively worse over time, right? But this is not the typical progression of the disease. Typical progression of the disease is there's a plateau, go along, and there's a crisis. Plateau, go along for a while, crisis, plateau, crisis, right? So if you're taking it a day at a time, you're going along on the plateau, okay, and then there's a crisis. And what you see family members do is they respond to the crisis. And by the time they finally cope with the crisis, there's another crisis. And by the time they cope with that, there's another crisis, right? So what you see among family members very, very commonly is they're always reacting to the last crisis, right? They're always in panic mode. They're always dealing with the crisis. They're always behind the curve. And the human body is just not constituted to spend years in a constant state of crisis. And that is why you see so many family members caring for dementia at the end of their rope, feeling like they're at their wits' end, feeling like they're going nuts, and literally carrying themselves sick. And you don't want that. You don't want that outcome. And the way to avoid that outcome is to plan, is to understand the seriousness of the disease, is to understand the caregiving difficulties, is to understand the nature of the progression, and to plan ahead for all the eventualities that definitely will come. For example, what's going to happen to the person's finances when they reach the point where they're no longer legally competent to handle their finances? If there's not someone or some mechanism in place to make those kinds of decisions, You're going to end up with a court-appointed guardian, and that's a nightmare. So you don't want that. What's going to happen when you might need someone, a personal care assistant or someone else to come in and help? Many people think, oh, that won't be necessary, but very, very likely it will. And when it becomes necessary, it will probably become necessary as a result of a crisis, right? And if you haven't done any research into your resources and options, you're going to be scrambling from square one to figure it out at the worst possible time. How do you make your home safe, right? What happens when the person becomes a fall risk, when they're no longer safe in the kitchen, when they're no longer safe in the medicine cabinet? I mean, you can dementia-proof your home, but you want to do that first. You don't want to wait until there's a fall or a burn or some other crisis in order to make your home safe. What's going to happen when they can't drive, right? I mean, very, very few people with dementia just voluntarily hand over the car keys. That just isn't likely to happen. If you're going to have to take away the car keys, and you eventually will, what you want to do is to start laying the groundwork for that as early as possible, or at least thinking about how you will do it and what resources and what people you can bring in to help. Because if you wait, you'll probably be trying to figure all that out in a crisis. Here's a more emotional one. Many people find that they have to tell little white lies to their loved one to get them to do what they absolutely need to do. And that can be very emotionally difficult for people. But if you don't think about that fact ahead of time, think about how you're going to cope with it and how you process it, then you're going to be processing that emotionally at the same time as you're dealing with the crisis. And that's difficult. Probably the hardest thing for family members is dealing with what we call problem behaviors, right? Combativeness, aggression, agitation, paranoia, lashing out, delusion. These sorts of things are extremely difficult to deal with. Now, there are ways to cope with that. There are ways of communicating with your loved one that you can learn and practice that minimize the likelihood of problem behaviors. There are ways you can structure their environment that minimize the likelihood of problematic behaviors. There are ways you can structure their day and their time that will minimize the likelihood of problem behaviors. And there are also ways you can respond when problem behaviors do occur that will minimize the harm. But you can't go back in time. You need to think these things through and practice them and put them in place ahead of time in order to minimize the difficulty of these behaviors. For a great many families, it eventually becomes too difficult to care for the person at home, and they need to be in a care facility. That is not a failure. It's just recognizing the reality that people who need a certain level of care need to be in an environment that can provide that care. Nobody thinks it's okay to treat their, if their loved one has blood cancer, to just treat them at home and not send them to a hospital, right? Because when they have that need, they need that kind of care. Same with dementia, same exact thing. However, when it becomes necessary, it often becomes necessary as the result of a crisis. And so if you haven't explored care facilities, if you haven't toured them, interviewed them, compared them, gotten on waiting lists, you will be trying to deal with that in a moment of crisis, and you're not going to get as good a result. And how do you pay for all that? Well, I mean, there are not many, but some methods that will help you to pay for these sorts of things. But again, you have to think about them in advance. You can't wait to the last minute. So, there are a million tips, techniques, tricks, strategies to make all different aspects of caring for someone with dementia easier for you and easier for them. And our book, The Complete Family Guide to Dementia, is chock full of all of these practical tips and techniques. But the overriding thing, and the thing I would most want to leave you with, is the mindset. Is that you can't be behind the curve. You can't always be reacting to the last crisis. You have to understand the disease. You have to understand the progression, where it's going, and plan ahead. You want to be ahead of the curve. And part of your planning, I'll leave you with this. You have to prioritize your own mental and physical health as a caregiver, because this disease is incredibly dangerous for caregivers. Remember what I said earlier, 18%, that's about 1 in 5 people. 1 in 5 people who provide care for someone with dementia will get sick themselves, will seriously damage their own health as a result of caregiving. And you do not want to be that 1 out of 5, right? You want to prioritize your own mental health and your own physical health, because doing so is not only good for you, it's not selfish. It's not just good for you. It enables you to provide the best possible care to your loved one. And if you don't believe me, there was a huge study done at Berkeley, thousands of families, and what researchers found is that when family members prioritize their own mental and their physical health, their loved ones live much longer, on average more than a year longer, and they have better outcomes and better quality of life. So caring for yourself is not selfish. Caring for yourself is actually, and you care for yourself by understanding the disease and planning ahead and staying ahead of the curve. That's better for you, and it's also better for your loved one. So that's what I would want to leave you with. I hope that's helpful, and I will turn it over to Brent, who will give you some clinical perspective on all this. Thank you.
Thank you, Tom. And thanks to everybody. It's great to see a big audience today, and I'm already seeing some really great questions in the chat. I'm going to avoid answering those till the Q&A. So my name is Brent Forrester. You heard a little bit about my bio. Working with Tom has been a pleasure on this book, and speaking to audiences like you all around the realities of being a dementia caregiver. So what I wanted to do is to highlight some of the realities that many of you have faced that in some ways are barriers to early recognition and diagnosis of dementia, and some ways for families to think about navigating the healthcare system given some of those challenges. Talk a bit about behavioral symptoms of dementia, and also some of the common challenges and how you may want to think about managing those. And all of this in the next 9 minutes. So first of all, why is it that so many people, as Tom was saying, don't come to understand or recognize that they have a diagnosis of dementia, aren't diagnosed by the medical community until they're already in the moderate stages of the illness? Half of the 6.9 million Americans with Alzheimer's disease today in the United States, half of those people are not diagnosed. And of the half that are diagnosed, they're not diagnosed until they can no longer drive or pay their bills. They're already in moderate stage illness. And there are many factors that conspire to delay diagnosis. Some of those are the person's not recognizing there's a problem. The family is feeling very worried about what's going on, and they're afraid to face the fear and the reality of what that might actually mean. But there are also factors that are unfortunately systemic in the healthcare system that contribute to a delay in diagnosis. And I'm sure all of you have heard this at some time or another, where a primary care clinician or other non-specialty clinician, non-specialty in the world of dementia care, that is, who figures, oh, you know, Mrs. Jones, she's just getting a little bit older. This is normal aging related memory loss. I wouldn't worry about it too much. They're performing fine. They're totally oriented. And there's really no systematic assessment of cognitive impairment. There's no attention to routine screening in primary care, even though it's built into an annual wellness visit once we all hit 65 and are on Medicare. That's not done consistently. And there's a lot of trepidation on the part of primary care clinicians, either because of lack of time, lack of knowledge, or feeling comfortable with making a diagnosis and helping guide families through the steps that they need to think about in the dementia care journey. The good news is we've had about 15 years now of studies that have looked at models of care that come into primary care settings where diagnosis and treatment and communication about diagnosis and helping families navigate the journey of dementia care, and how do we keep people living higher qualities of life and keeping them safe at home and meeting their care needs, and deprescribing medicines that are dangerous. There have been models that have been studied that show that clinical outcomes for patients, for family caregivers, and in terms of overall use of healthcare resources and costs are all better when you intervene with a dementia care team in primary care. And there are a number of these models that have been developed, the Aging Brain Care Program, the Alzheimer's Dementia Care Program out of UCLA, and more recently, and probably most scalable, is the Care Ecosystem Program out of UCSF. And these programs combine various clinical and non-clinical personnel to support the primary care practice in diagnosis and treatment and all the rest. The partners that actually are members of this team include social workers, nurse practitioners. Some of the teams include pharmacists, but very importantly, there's often a non-clinician involved. And this role is now being termed the Dementia Care Navigator. And in November of last year and launching in July of this year, the Center for Medicare and Medicaid Services, Medicare's innovation arm, otherwise known as CMMI, launched a program called GUIDE. GUIDE stands for Guiding an Improved Dementia Experience. And it calls for the implementation of these care models and a Dementia Care Navigator team in particular within primary care or even in specialty memory clinics to help guide the treatment of people with dementia and support their caregivers. This is going to be a game changer because up until now, there was no insurance that would pay for this type of care. It was all people who had, resources and connections to pay for geriatric care managers, or to pay for home health aides, or to pay for and to coordinate the care themselves and to figure out the resources themselves. And the Alzheimer's Association often would play a big part of that with their dementia care consultation program. But now there's going to be a federally funded model. So it's worth thinking about. Again, the first sites just launched in July. It'll probably be about a year. So the other sites, like our site at Tufts, will be up and running next July. When this is more widespread, if this model in fact works, in terms of clinical outcomes and cost savings, it could be a game changer in terms of recognizing some of these current systematic problems, like I said, that exist in healthcare. So that was one thing I wanted, the delay in diagnosis and why it happens. And I think as a family member, I have a mom right now who's 82, and she has a son, me, who knows this stuff. And there have been cognitive issues for the past 5 years, and they've been relatively stable, but they're there, and she really doesn't want to get a further evaluation. And so I know how hard it is, even when you know what you need to know as a family member and you have all the resources in the world, getting the diagnosis and having family members face what's going on is really hard. The other thing I wanted to talk about is the problem that complicates dementia for the vast majority of people are the behavioral and psychological symptoms of dementia, like anxiety or agitation and wandering or physical aggression or depression or paranoia or hallucinations. These symptoms are nearly universal over the course of the illness, but understanding their cause is the key to figuring out how best to manage them. And oftentimes when you ask families, what is it that's the hardest part of this illness? It's the day-to-day care of like activities of daily living, but it really becomes problematic when these behavioral symptoms rear their ugly head. And there are safety issues, there's worries, and quality of life goes downhill. Family members get burned out and exhausted. Tom talked about the rates of associated morbidity and mortality associated with caregiving itself. But a lot of that is driven by these behavioral symptoms. And Tom mentioned one example of that with his mom. These symptoms are treatable often. Most of the time, they're treatable with either behavioral interventions or medication interventions, but it requires a holistic approach, and it requires an assessment by a clinician who understands how to figure out the cause and implement a treatment plan. This is why some of these care team models that are going to start sprouting up can be so helpful. There's been a lot of research on this, but I think the most important thing for you as a family caregiver to know about is recognize this is happening and trying to get clinical assessment and help for it. The other thing I just wanted to talk, the two other really quick things I just want to mention is some of the, if you will, psychological issues that make this illness so hard for caregivers. One of them is that the nature of the relationship between the person with the illness and their loved one essentially changes when they are diagnosed and experiencing the symptoms of dementia. Adult children feel like they're becoming parents. That does not feel comfortable. They're starting to make decisions for their parents. Sometimes the parents will actually say that they feel like they're being treated like a child. My dad was having a really rough time from a mental health perspective about a year ago. And he told me, as I was trying to be a caring son, coordinating his care and connecting him to resources and all of this, he said, you know, you're talking to me like I was one of your patients. Well, that's not easy to deal with. After he got better, we actually talked through that quite a bit. But these are the kinds of things. It's like the nature of the relationship changes when you're dealing with mental health issues and dementia in older adults. And if it's a spouse caregiver, it also changes quite a bit, of course, for so many different reasons. So that's one psychological issue that's important to be aware of. And again, as Tom said, in our book, we talk a lot about being proactive and not reactive and trying to address these. The other is this, this is such a long illness. And as someone's loved one changes emotionally and cognitively and functionally over many years, you know, we go through a period of grief and mourning and loss. And a lot of the reactions that sometimes, you know, we all as caregivers have is we're responding in a certain way. We're getting anxious, we're getting depressed ourselves, we're getting irritated and irritable. We're not focusing or concentrating. And sometimes it's because we're grieving, and it's actually a manifestation of our own grief. And I think, you know, addressing the grief that you're experiencing as a caregiver is critical to being able to be as strong as you can be during the process, so that you can be there to help out your loved one, to recognize that it's there and to get help for it. It often goes ignored. Oh, I can deal with this myself, I'm fine. But you're fine until you're not fine. And the whole goal here, and really the whole message in the book, is really this being prepared and to plan and not to wait for that crisis to ensue. So, you know, both Tom and I could talk endlessly about these issues. I think someone's going to put in the chat the link for the book, but I think maybe Molly, we should open this up for our Q&A and go from there. So thanks for your attention.
Thank you, Brent and Tom. That was great. And I'll invite, right on cue. Thank you, Tom. That was really fantastic. And I think the more you spoke, the more questions we were getting in the chat and the Q&A. So I think just a marker of how valuable this content is and this support. So thank you. So I can kick us off, and I did put a link to the book in the chat that they were mentioning. So this was a question that we got in the chat about how to plan for the digital age, how you would recommend talking about it before it's a problem. What do we do when the time comes when our loved one is continually vulnerable online? Would you recommend things like parental controls or changing passwords? Is this something that you've seen in your work or with, you know, your family members?
Tom, you want to start?
Sure. What a great question, and what a difficult topic it is. And I think there's no one answer, because I think it depends a great deal on two things. One is the progression of where you are in the progression of the disease. And secondly, what the attitude of your loved one is, and how much self-awareness they have, and how difficult they are about it, or understanding they are about it. So I think there are, you know, lots of ways to approach it. One of the things I talked about earlier is finances and getting control over finances, because I think this is primarily a financial concern. And having a structure or a person or a document in place that will allow someone to have control over the person's finances. And the more you can do that, if you can do that, you can try to, you know, minimize the danger of the person getting taken advantage of financially. For instance, it may be possible to alert your bank or your credit card company or your investments or whatever, that the person has dementia, and that they, you know, you want to put strict limits on how much can be taken out of a credit card, how much can be taken out of a bank account, or it should trigger an alert to another person if something like that happens. So that's one thing that is possible to do. The other thing is that, as people, many people feel like as they start to progress in the disease, they want to hold on to some sense of control or power. They want to hold on to their money. They want to hold on to all these things that give them a sense of power. And so sometimes, and it's, some people think this is okay, some maybe don't, but people, older people, people with dementia feel better if they have a wallet with a few dollars in it, even if it's just a few dollars. It's a psychological anchor. If they have a checkbook, there may be $5 in the account, but it gives them a sense of psychological power. It's an anchor for them. It makes them feel better. And you can cancel credit cards and let them keep the credit card and think they have it, and so forth. And maybe that's, as I said, a little white lie, but it may be something that will protect them from a disaster. So I think, I think there's no perfect way to do this, but I think it's kind of a judgment call as to where they are and what their attitude is. And that will change over time. And it's another reason to sort of think ahead. What happens when they can't do this, and what will we do, and so forth. So that, I don't know if that's much of a help, but it's my thought on it. Now, Brent.
The only thing I would add is it's such a great question, as Tom said. When I think about how do people with dementia at home get in trouble, I think about falls, I think about wandering, I think about medication mismanagement, I think about leaving the stove on. And at home, at least, I up until now with the digital age, I don't think we were as worried about the risk for people being taken advantage of financially or worse online. Now that that's becoming more of an issue, to say the least, I think this might require some further, this is a great issue for an organization like the Alzheimer's Association and other groups to tackle with some of our digital professionals who can help us think about ways to systematically address this. Without the tech experience, I would not know how to actually even implement parental controls for my parents. So then adult children and spouses would need to have some part of the training for safety is going to have to be an assessment of digital safety, I would call it. But I really appreciate this question. I guarantee I'm going to bring this to some of my colleagues for their input. We should probably move on to some other ones.
Thank you both. Those are very thoughtful responses. And I think you're right. I think this is something that a lot of people are having to deal with and will have to deal with more and more. So the next two questions have to do with getting a diagnosis. So the first is, what would you recommend as far as getting a dementia diagnosis? Does one need a diagnosis? And do we get baseline testing from a physician? And the next was a person who said they were told by the neurologist that insurance does not cover blood tests to diagnose Alzheimer's, and they need to go by the disease progression to diagnose. Is that accurate?
So for part one, there are many reasons why getting a diagnosis is important. And the most important reason is you need to know what this is to plan for the future. And if it's not dementia, then there may be something else that's quite treatable. So if somebody's having symptoms of cognitive impairment, it could be due to Alzheimer's disease. It could also be due to that medicine they're taking over the counter at night to help them sleep, called Tylenol PM, that has Benadryl and diphenhydramine is the generic name. So, or they could be abusing alcohol or suffering from depression or having unstable kidney function or diabetes. There's so many masqueraders, if you will, of cognitive impairment and functional decline. So getting a diagnosis includes excluding other causes that are highly treatable, that are not neurodegenerative dementia with inexorable decline. So that's one really important reason. The second is getting a diagnosis helps you plan for what we can do for people, as opposed to just thinking about what people with dementia can no longer do. Like when we think about dementia, oftentimes we think about, well, the person with dementia can't drive, and they can't pay their bills, and, they're not going to be able to independently make decisions. But what we don't think about as much, which we really need to, is what can they and really should they be doing to proactively help support brain function despite the progression of the illness? How do we engage people in socially meaningful activities? How do we keep people's brains active with games and exercises that they still can do? How do we keep people exercising and paying attention to nutrition and making sure they're getting the medical care they need. So I think the proactive approach to all that we can do, I think, is another reason why diagnosis is so critical. So the way to get a diagnosis is, it's really, even with blood tests, we'll talk about in a minute, but even with fancy testing that's now coming around, it essentially remains a clinical diagnosis, which means the history that the patient and the family says about what's been going on and over what period of time and what symptoms are and what they've noticed and functioning, and then objective cognitive assessment. There are some screening tools like the mini mental status examination or the MOCA, the Montreal Cognitive Assessment. Those are things that can be done in a primary care setting, or can be done in a specialty, dementia clinic, memory care clinic, if you will. But the more detailed version of testing to establish diagnosis is what's called neuropsychological testing. And increasingly, those tools that used to be 2 to 3 or longer hour pen and paper tests are now being converted to digital tests that can be done in a shorter period of time and collect way more data. And there are a number of companies now that are growing to do all of this. This sort of gold standard place to get a diagnosis beyond primary care would be a specialty memory clinic, which could include geropsychiatry, can include neurology, often will include a social worker and a neuropsychologist. And it will help to not only establish the diagnosis, but to give families sort of a guidance on next steps in terms of planning along the whole, journey. The good ones will do that. The blood test issue. So up until, the last couple of years, the treatments that we had available for Alzheimer's disease were what we called symptomatic therapies. They helped to alter brain chemicals that would change with the progression of the illness. And the two classes were the cholinesterase inhibitors. One of the questions is about ribostigmine. That's a cholinesterase inhibitor. It increases acetylcholine in the brain. And the other one called memantine. And for Alzheimer's disease and many other dementias, the gold standard was the combination of the two. But neither of those drug classes address the pathology of Alzheimer's, which is the most common form of dementia. And the two pathologies in Alzheimer's are amyloid plaques and tau tangles. And so it's been almost 18 years now that we've had a way to visualize the amyloid in the brain using a PET scan, where someone goes into a scanner, something's injected, a ligand into their arm in the bloodstream, goes up to their brain, and it lights up the amyloid. So that's one way to look at amyloid in the brain. The other way is through a lumbar puncture or CSF, that we call that a spinal tap. But the other way, which is now becoming really the hot topic in the field, are these blood-based biomarkers. So now there are tests that will detect pretty accurately if you've got amyloid in your brain. They're not quite yet ready to be used in clinical practice, absent these other things like cognitive testing and everything else. I think we need to do all of that still, and probably will, always need to. But if someone wants to be considered for one of the newer treatments that are on the market now, the antibody therapies for the anti-amyloid therapies, they have to have evidence of a brain biomarker of amyloid. And now we can visualize that with amyloid PET or the spinal tap, but we're also now seeing that these blood-based biomarkers correlate really well with those tests. They're cheaper. They're currently not yet reimbursable by insurance, but they will be. What I would not do is get that test on your own, not under the guidance of a clinician who knows what they're doing, because you won't know how to interpret the results. And you might over or under interpret things, and it's only at the end of the day a test. It's not a clinical assessment.
The only thing I would add to that, which is great, is a common feature of dementia in both people who have it and people who care for it is denial. And denial is not surprising, because this is a horrible disease and nobody wants to think about the fact that they or a loved one has it. So many people who are developing dementia symptoms are in denial. And if you say, let's get a dementia diagnosis, they say, no, I absolutely do not want that. And often you have a situation where one family member wants a dementia diagnosis and other family members are highly resistant and don't want that. So, you're often in a situation where you want a diagnosis, and maybe, yeah, that's a great thing to do is get a diagnosis, but there are people in the family who are opposing you. And, in that kind of a situation, it may not be worth, dying on that hill of getting a medical diagnosis. the more important thing, and I think Brent mentioned, is that sometimes the symptoms of dementia are really symptoms of something else. So one thing it's possible to do is, in some cases, is to talk to the person's doctor and say, this person is experiencing symptoms that seem like dementia. Here's what they're doing. But they don't want a diagnosis. Could we bring them in for some routine tests and essentially rule out other possible causes? And if you can rule out other possible causes, then you have a de facto diagnosis, whether it's official or not, and you can at least kind of act on that in your own mind. So that's the only thing I would add.
It's wonderful. Thank you both. And I want to call out a comment that was made in the chat in response to our question earlier. Someone said that for their mom, she needed a wallet, and this person made a laminated copy of her license. I took out personal info, except her name. I left a small amount of cash and coins, old checks, and used fake credit cards, and it was so helpful. And I think that sort of piggybacks on what you were saying, Tom, about your experience as well. And that psychological anchor that you mentioned, which I think is a really helpful term to come back to. So we're just about at time, but I don't know if you have any last comments or recommendations for those caregivers who are on the call, or tips for them as they continue in their caregiving journey.
Well, one thing I just wanted to mention, while I was there, was also a comment in the chat about navigating situations that change from day to day, person not remembering, but the last part of that I did want to address. How do I find a therapist for myself? And that person is a therapist. Being in the world of mental health does not protect you from having to deal with this emotionally, and also does not necessarily mean you have connections for therapists who know how to manage this. But I would start again, perhaps with the clinician that helped with the diagnosis, or your primary care clinician, because sometimes counseling, formal counseling, psychotherapy is really helpful. You can't always just figure these things out yourself. Some of it's coaching and education, but a lot of it sometimes needs to be psychotherapy, or building skills, resiliency skills to cope with some of these challenging things, including the one you mentioned about how symptoms change day to day. And I think one of the reasons why that's so difficult is it's so frustrating. And you still see the person as they once were. And so it's hard to imagine that they couldn't remember the conversation from the day before, but you need time to kind of plan a way to address that, and also to deal with the feelings associated. Tom, you want to say one last thing?
Sure. Just in response to that comment in the chat, she talks about someone who the person with dementia agrees to one thing one day, and she does it, and the next day they don't remember agreeing to that, and they're angry. And the only thing I can say is that the good news is the day after that, they won't remember that they didn't agree to it and that they were angry. So sometimes there's a slight side benefit to the lack of memory, but it's rarely worth it to put up a huge fight and to insist and to argue and to try to get the person to acknowledge something that in their mind didn't happen. In their mind, what they think happened. And it's hard to talk people out of things that they genuinely believe. Probably better to redirect, get them onto a different topic, and then by the next day it'll probably all have blown over. Don't ever make it about you, because it's never about you. It's never about you. It's not about what you did. You don't have to persuade them that you're right. It's because it won't work. That's not going to happen. And the last thing I would say is that the mantra of our book is care smarter, not harder. Everybody, cares harder and harder and harder. And in 1 out of 5 cases, they care themselves ill. And so the secret is care smarter. And that's what our book is all about. So I hope that's helpful.
Well, this was wonderful. Thank you both. I just put some information in the chat about mass options as well. If you are a caregiver and you're looking for support as a caregiver, for support for your loved one, or for professional behavioral health support, you're looking for a therapist, like Brent said, this is incredibly helpful. And mass options will connect you with your local provider that can connect you with the right supports. And then Mass Caregiver at mass.gov if you have questions, comments, recommendations for the webinar series. We also, once you close the webinar, have a survey. We want to hear your thoughts on today. There's never enough time. These are two real experts in the field. This was such a treat to have you and to have Pam at the beginning. So I can't thank you enough. What a testament that we were having questions come in right until the very end. And we have just as many people on right now as when we started. What a testament to what valuable support and information and knowledge that you have. So thank you for joining us today, really.
Thank you, Molly. Thank you all.
Mm,
Thank you.
Thanks for the opportunity. Thank you, everybody.